We're here. Wonderful. Thank you so much for being here.
This is very, very exciting. I think that there's so many great things to talk about, and I, you know I'm excited anytime I can see people getting better. And I don't think there's a better example than the wonderful things that you've been doing at Marama. Actually, I just got off another podcast a couple of minutes ago, and just again seeing people and hearing. I got a call this morning about someone who had an abnormal EEG. They started doing the protocol, and then EEG completely normalized. And this was actually from Dr. Geraldine Brosfield. Very, very excited to see. So nothing makes my day better than seeing success with people in need.
I was sharing that with somebody earlier today that my favorite words to hear are, I got my mom back. And
Yes.
that
Yeah.
is just, yeah, it's so incredible. There's no more fulfilling work in the world. And Dr. Bredesen, I just want to start by thanking you. You have given me my purpose. I'm going to get emotional, but really, you have paved the way for all of the work that I do in the world. And really been just at the absolute forefront, saying this before anyone else was. And all of a sudden, it feels like things are shifting. Finally, CNN had their docuseries that Sanjay Gupta put on, and finally the world is starting to accept this. But you have been saying this for decades, and I want to start, if you don't mind, by just asking, when was the first moment you realized that there were solutions for people who are suffering with Alzheimer's?
Yeah. Well, so I actually got interested because this is an area, neurodegeneration is an area of the greatest biomedical therapeutic failure. And when I was studying as a neurology resident, like we would look at the pathology, but we never had anything to offer anybody. And so I remember my wife used to laugh and she's saying, "You're always doodling on your yellow pad." So would have these yellow pad, these tablets, and it would just be going through a million ideas. What if we did this? And what are the molecules actually affecting the synaptic performance? What is actually driving these things? Why is it so common? I mean, Alzheimer's is the second leading cause of death in the UK today. It's the number one cause of death in the UK in women. It's incredible. It dwarfs the pandemic. 45 million of the currently living Americans will die of it. So I would be doodling with this and think, and then you kind of have to get them all to fit together. I would say, well, if this is the way Alzheimer's works, what does that mean for ALS? And what does that mean for Parkinson's and Lewy body? And so we started to look at these and started to make sense in like 2008 or so. We started seeing that, okay, so APP, can go one way, it can go the other way. It's like, why would APP be set up that way? And so we thought, okay, maybe one of them is more for building and the other one is more for pulling up. But why? Why would it pull back? And why the old thing about why do you have amyloid? Is the amyloid there to give you Alzheimer's? Well, now it makes a lot more sense. It's there to help you. Your body is not trying to kill you. It's trying to respond to the insults that you have put it through. And so we started seeing, okay, there are these two different things. So we started actually looking for drugs in about 2008 that would switch you from synaptoclastic to synaptoblastic. But of course, when we identified some, and then I thought, well, but how do we know it's going to stay? Like you're doing something that's non-physiological. We need to understand why it's over on the bad side to begin with. And so I thought, okay, if we do this drug trial, but now we add, at first I thought, okay, let's add some brain training. And I thought, okay, let's add some, exercise. And then after about the third thing, I had it up on this big whiteboard in my office at the Buck Institute. And I was like, right, okay, let's see, we have this. And I thought, why would we leave anybody less than completely treated? Like, what kind of an idiot am I for thinking we're just going to add one little thing? And then I saw it, so everything kind of changed. I thought, oh, what if we did everything we could to change? And I still didn't quite understand, well, what are all the things that they're hitting? But then when patient zero got better, which was 2012, and called me actually in July of 2012, I was like, okay, we're on the right track. This is the right thing. And I think what's happening now is like we're entering a golden era with things like Marama and things like p-tau 217 and things like, homotaurine and all these things that we're now learning. Okay, now we can keep tweaking, making it better, 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 better. We still need to understand how to take someone from MoCA of 0 to 30. Nobody's ever done that. But as you pointed out, we can go to where we can get them to be functional, where they are able to take care of themselves again. They're able to do things they couldn't before. We now need to know, how do we get that? The rebuilding is going to be really important. How do we bring back synapses that have been lost? So I think we really are entering a golden era, instead of there is nothing that can be done. In fact, there's a lot that can be done. And I should just mention one other quick thing, which is I've been trying to understand, how did we get here? And here's what's fascinating. As we were evolving 5-7 million years since the simians became hominids, at each step, you're selecting performance over durability. So we have these very, very highly honed sub-networks in our nervous system. We have the whole sub-network for neuroplasticity. Do you know you can store 2.5 petabytes in your brain, which is about 2,500 home computers, or one of the largest supercomputers in the world inside your skull. So you have this unbelievable object there. So you've selected for performance, because that's how you evolve and that's how you beat the competition. But in so doing, you're selecting against durability. And so we have the same thing for motor modulation. You've got this amazing fine-tuning system that goes awry in Parkinson's. Now you've got motor power. And one of the things I was calculating, I'm putting it in the new book, which is if you stomp down on your accelerator in your car and you get this huge, the amount of effort it takes to stomp down versus how much horsepower you get, the amplification is between 10,000 and 100,000 fold. You get at least that much amplification when you go from a thought, I'm going to now tense all my muscles and do the maximum amount of work. Instantaneously, you're in a fight, or you're doing something where you have this dramatic power surge. You go from about 1/1,000,000th of a calorie per second to about a half a calorie per second, like that. And so these systems are operating at max performance, and they are subject to loss of durability. This is why we age. This is why we have neurodegenerative diseases. So the good news is, as you well know, we can now start to define what's needed in each system. And my hope is, over the next decade or so, with the help of AI, we'll be able to get all the constants for each of these pieces. So we'll have a very accurate mathematical formula. So we can say, okay, this person has 2% this, 5% this, 17% this, and you'll know exactly. At least now we know it qualitatively. We can say this person, it's mostly about these 3 toxins and those 2 pathogens and some insulin resistance, whatever, and go after those. And each of these systems has its own Achilles heel, which is really interesting. So, if it's macular degeneration, really it's about the fact that it's got a supremely high metabolic rate. If it's Parkinson's, of course, it's about mitochondrial respiratory complex 1. With Alzheimer's, it's, I think, a little more diffuse, as we see. It's really about the network. But each of these has their own Achilles heel. So like never before, we can look and say what's wrong, and we can fix it. And obviously you're doing it, which is really great to see. And we're getting all sorts of wonderful results. We're in the middle of the next trial now, which is going very well.
That's amazing. Now, you mentioned you have a book coming out. I also have a book coming out, and it sounded to me, and you've probably had this experience, I've been learning so much through the collaboration. I've been able to join your calls at the Pacific Neuroscience Institute, where you are involved in treating patients under a really large institution. And for me, I see the next steps, and my hope contributing there as much as I possibly can, is that there will create a model that can be picked up in other large systems. That yes, people for a while will probably need to come to Pacific Neuroscience Institute to get the best workup. I mean, there are just these incredible people so many intelligent people on those calls reviewing cases, and it's just a dream come true that I get to join you guys sometimes. And in that, I've learned so much that I wish I put in my book that's coming out next week. Now, you've published at least 3 books that I am aware of, and you have another one that you're working on. Now, do you just have to keep writing books because you keep learning stuff? Is that how this world works? And is
No,
there
and mine's not coming out till next week. This is about your book, so we're very excited about your book, and I love your title, Reversing Alzheimer's, because people will look and say that's impossible, and yet you've shown very clearly again and again that it's absolutely possible, and you've got the data to prove it, and you've got the patients to prove it, and as you mentioned earlier, there is nothing better. All the years in the lab that we did, it was great to see all these nice facts and all these data, but ultimately it's about seeing it play out. When going from the yellow pad that I used to work on to actually seeing people get better, and it's so great. And to hear people who say, thank you for giving my brain back, or spouses who are saying, oh my gosh, this is so wonderful to see. People who are who before would see their family member would go into an assisted living facility and they would just take, as they would just take a nosedive. They would get much worse. They would be given all sorts of drugs to quiet them down, horrible food, stress. I mean, it was terrible. And I remember actually one guy telling me, he sent his wife to an assisted living and she just took a nosedive. So to have the possibility of getting better, and at the very least that they stay the same, so that they can stay there for years. Their family they're so happy to see them. It's great. It's really changing the fundamental way we think about things. So I think it's great that you're writing about this in your book. I also know you've got that wonderful chapter on the future. Where is this going? And then what are the things that you can now add on? I always think about, how can we keep optimizing, because there's so much that can be done. And I love that chapter.
Yeah, so one of the things that happens, right, is we keep learning and we keep wanting to get this information out there. For our special guests who are joining us today, we have over 500 people joining us right now. And I think that they're here because they're exceptionally interested. They've probably read your books, are familiar with what is kind of in the forefront of the research. But is there anything that you can share today that you've learned in the past couple of months, maybe since January or in the past 6 months, that you feel like it's really important for people to know about, or maybe even something that's become more in the forefront of your mind more recently?
Yeah. So, what I've been learning about is when you look at this, I looked at this initially as a kind of unidimensional balance. So you're either in connection mode or you're in protection mode. And it's very interesting to me that there's a lot about kind of modal systems. You're in sleep or wakefulness. At sleep, you're really good at detoxing. You're really good at restoring. With wakefulness, you're really good at getting things done and learning new things. So they really work together. And the same thing happens. You can even see it in APP itself. You cleave it one way, it's about connection. You cleave it a different way, it's about protection. And you're now using your resources to fight organisms and deal with these insults and sequester and bind and kill of these various insults. So I've always seen this as kind of a unimodal, protection connection. Well, what's turned out to be quite interesting is you see this at every level. And so actually I was reading, one of your mentors' books, Dr. Neil Nathan, who's just come out with his book, as you know, The Sensitive Patient's Healing Guide. And of course, he obviously agrees with you on many things.
Well, I learned from the best. You and him are my 2 primary mentors. I'm so grateful.
So the thing that struck me about his book is that if you fix everything else, you still may have an issue if you've got a limbic system, which is kind of in this threat stress. Now, again, as a scientist, I never used to believe in any of this, like, oh, stress, get over it, that sort of thing. It was like way too woo-woo for what we were doing in the lab. We were looking at molecular biology, not at stress and threat. But I was reading Annie Hopper's chapter, which is actually the first chapter in the book, about her, the things that she's doing. And actually, I just talked to Dr. E earlier, who's saying she has switched over from treating mold and then doing more of the Annie Hopper type stuff or the Dr. Gupta stuff to flipping it and starting with. So the idea of you really need to retrain, again, something that was not chemical enough for me in the past. But that's turning out to be, whatever works is what we want to do, what best outcomes. And I do realize that we need to calm people down. We need to get them. So it's not just about fixing their chemistry. It's also about fixing their synaptic connections related to stress and threat. And I think of these people who have chemically sensitive, and the people with chronic fatigue, and the people with fibromyalgia, and the people where we've seen some young ones. They have what I call camelback syndrome. It's like everything's wrong. They can't get up out of bed. It's just like too far. And it turns out that I think a lot of the people who have cognitive decline have a little touch of that. They don't have it in spades, so people don't pick up on it and say, oh yeah, you are a sensitive patient. But their limbic system is telling them things are not quite right. And actually give a lot of credit also to Dr. Dr. Clausen, who has things on YouTube. And Dr. is actually a friend of our family, great guy, excellent physician. And he talks about how important stress and threat are to your health. So I actually think that has been an underappreciated area in the whole field of neuroscience. Now, obviously, this is an area where you are way ahead of me. I'm focused more on, did it make oligomers? Did it bind to the right receptor and all that? But how these things are actually coming together. Another thing that I've been very interested in the last few months is homotaurine. I think there is a chance that it's going to be something that can be helpful. What it's doing is preventing the amyloid monomers from making oligomers. And as much as this disease is not just about amyloid is there because you're asking it to be there to kill these microbes and things. But when you've already got too much around, what you do want to do is keep it in a less damaging state. The monomers are not so damaging. And typically not damaging, and actually the polymers, these huge lakes of it, are not particularly toxic. It's those oligomers that are there to kill the bacteria, and unfortunately, they also have a synaptotoxic and mitochondriotoxic effect. So again, I really welcome your book. I think people are going to be so enthusiastic. You talk about it as, the toolkit. So here's a toolkit. If we could change one thing, it would be for people to understand that something can be done. If we could get people to come in early, you go through those 4 phases, as you well know: asymptomatic, SCI, MCI, dementia. If we could get everybody to come in asymptomatic or SCI, there would be very little dementia. You can do so much with people and help them and prevent them. I always ask people, have you seen a single person who went on prevention when they were truly asymptomatic and did the right things and still developed dementia? I've never had one person say yes. It'll happen at some point, but it's got to be extremely rare. And then with the SCIs, as you well know, someone comes in with SCI, I'm thrilled. We're going to fix them.
This is subjective cognitive impairment. Those
Subjective
first
cognitive
signs that you are misplacing your keys or your phone,
Right.
my brain doesn't work quite the way it did 10 years ago. And that is exactly when we want to capture people, because it's so much simpler, so much easier. I want to let everyone know we started a couple minutes before 4:30 because we were excited to see each other. And so don't worry, you're not late. We did get started at 4:27. So you just missed us greeting each other, saying hello. And we have tons of questions in our Q&A here. So we're going to go there now and start taking them. I just want to acknowledge Dr. Bredesen. Thank you so much for your time. Thank you so much for your work in the world. I will never know all of the molecular biology and all of the pathophysiology and everything that you've collected over your lifetime of experience, but I do have the privilege of putting your work into practice, into the implementation of working with health coaching clients, with patients in my office, and with residents at Marama and the Clear Mind Center in Kansas. And that privilege is just profound because I get to help people get better, get their lives back, get their loved ones back. And I would not be here. I would not be doing this if I hadn't seen your talk at a mental health conference many years ago in 2017, and then done your training, and then had the privilege of collaborating even more closely with you over the last few years. Thank you, thank you, thank you for your time and just for all of the work that you've done in the world and how many people you have helped.
And thank you for all the stuff you're doing to make people better. I have to say, I was very impressed when you presented the patients to at PNI. You had gone through very thoroughly, looked carefully at what was actually driving the problem, addressed them, and people getting better. So it's great. And of course, we still have so much to learn. There are people who don't get better. And the question is why? What's being missed? What's going on here? And so, we're going to keep seeing more and more. We're going to keep understanding this better and better and making it better and better. So thanks for Marama. Thanks for your trial. The trial is really important to get people to see, yes, you can actually do a trial and show efficacy. And of course, thanks for your new book, Reversing Alzheimer's. I think it's going to help a lot of people.
That's my hope. I have so many people who've come into my office with your book, with it dog-eared and patients underlining important passages and using it as a Bible, if you will, to help them reverse their cognitive decline. And then they come in to get the medical piece as sort of icing on that foundational cake. And what I hope to do is make it even a little bit more accessible. There are stories that are inspiring from my clinical experience, our residential experience, and our coaching experience. And I'm trying to make it bite-sized, talking about a lot of the foundational pieces, because you've done so much work training doctors, making the medical piece accessible. And although some people get overwhelmed, I
Yeah.
want the message to be, just get started. No one in our clinical trial did everything.
Yeah.
I don't know if anybody in your clinical trial does everything. It's impossible, I think, for most people, but just getting started, just going down this path. The first step is probably being here, joining the community, reading the books, learning more about what you can do.
Absolutely. And as you said, just getting started, because if you can find those things, I mean, I look forward to the day when we can say, okay, it's just these 3 or 4 or 5 things. I've never seen a person where it's just one thing. They've usually got some insulin resistance. They've usually got some inflammation. Even if you don't see it on an HSCRP, they've got their microglia activated in their brains. So that there's usually multiple things. This is a network insufficiency. This is driven by a chronic innate system encephalitis, mild encephalitis. So you can see, and you can just, if you can get the right things, as you well know, you hit that right thing and people get this bump. Sometimes they get a bump from EWAT. Sometimes they get a bump from treating an infection, a chronic infection.
Getting
Sometimes
into
they get a
ketosis,
bump from BHRT.
right?
Sometimes they get a bump from stress reduction, but you put these things together, and now you really start to see improvements. And it's just great to see that that's the way the network works.
So I want to go to our great questions that we have.
Yeah.
From Kathleen, how many avocados might one eat per day on the program? Do you have any thoughts about avocados?
Oh my gosh. I mean, I'm sure you know more than I do about avocados. I usually have them in my salad, and I usually try to have, 1 or 2 a day. And I don't know, what do you recommend at Marama?
Well, we use avocados routinely we'll use them in shakes and in, like you said, salads. They're with many of our meals. Now, there's not, with MCT oil or coconut oil, we'll often suggest using a couple tablespoons a day, and sometimes even more than that, because that can be the prerequisite for creating ketones, or the beta hydroxybutyrate can come from the MCT, those medium chain triglycerides, very easily. And so avocados, they don't quite have that magical effect of turning into ketones right away. They're not the particular type of fat that does that, but they do help us to have those better HDL levels. They're a great source of healthy fat that can help you to be more satisfied on a ketogenic diet. So I don't tend to limit avocados. Kathleen, you might share with us how many you're having. I also tend to have at least 1 a day. Sometimes I'll have 1.5 or 2 if they're about to go, they're ripe for like 30 minutes, right? And so if I have a couple that are perfectly ripe, I'll put them in a smoothie. They make smoothies really creamy, and I'll get more of them in. So from Robert, his question is, the focus here is on Alzheimer's. Do these methods also work with frontotemporal dementia?
This is such a good point, and I just heard about a frontotemporal patient today. So the answer is, for each of these neural subnetworks, as we were talking about, they have a different set of supplies and demands. All of these diseases, we now believe, are supply demand, where the supply is going down as you get a little older. The demand is going up because you now got inflammation, you've now got toxicity. And so you have this mismatch. And so you're literally pulling back. You can no longer support that size of a neural subnetwork. So you are pulling back on it. Now, frontotemporal dementia is an interesting one. It has the least. We can do very well with Alzheimer's. We can do very well with Lewy body, recognizing that in that one we have to adapt the protocol for more on the toxin side. We can do very well with vascular dementia. Frontotemporal is less common than those, and it's the one we have the least information about. I think the best hint currently about frontotemporal dementia is that it is a cousin of ALS. As Bruce Miller, the Alzheimer's expert, said years ago, most people who have frontotemporal have a little bit of ALS, and most people who have ALS have a little bit of frontotemporal dementia. There is some relationship there. And interestingly, the most common genetic components, not the majority of cases, but the most common genetic for FTD is called C9orf72. And that particular gene, it gives you both ALS and frontotemporal dementia. So there is some interesting relationship. If you look at the ALS side, can we get hints from that? This is really, instead of being more about the metabolic flexibility that we think about with Alzheimer's, it is really about having enough energy to remove the glutamate. We talked about power enhancement. So when you have that system, which is what goes awry in ALS, you have these massive power boosts. What could to get that sort of amplification, you have to have massive synapses, and you have to have what turns out to be, unfortunately, an excitotoxin. So glutamate is used at those synapses. It is tremendously stimulating. It would be like saying, I really have to do a lot for the next week to get my finals done, so I'm going to take cocaine 24/7 for the next week. You are literally burned out at that time. And so this is why, unfortunately, people who are super athletes are at increased risk. They're pushing the system 24/7. And so we want to be able to get people to clear their glutamate. We want to improve their overall energetics. This is an area where exogenous ketones may have an important role. And in fact, where too much fasting can be a bad thing, because you're now not giving that energy that you need to remove this. So the answer at the moment is we don't know a lot about frontotemporal. We don't have enough data yet, but we would still like to look at the same sorts of things, the toxins. We'd like to look at inflammation. We'd like to look at at various pathogens. There has been some work from Dr. Robert Hidea in Washington, D.C., and he's used things like oxytocin with some result, and then addressing toxicity. And I do worry about things like glyphosate, which are coming back repeatedly as being things that can give you these glutamatergic related diseases. And I think of ALS and FTD as being in that spectrum. So all I can say is, please get started as early as possible. There's no guarantee. We don't know nearly as much as we do about Alzheimer's, but I think that there's hope. And this is one of the things going forward that I think we can do better with.
From Leslie, for someone diagnosed with mild cognitive impairment, what do you consider the ketone range that would support optimal brain health?
Yeah, great point. And again, it's the metabolic flexibility. So usually, when you and I see people, they've lost both. They've lost the ability to utilize that glucose, and that's what the PET scan shows you. That's what an FDG PET scan of Alzheimer's brain is: reduced glucose utilization, temporal and parietal regions. But then, because they're insulin resistant, they prevent themselves from making ketones. So I consider it a metabolic emergency when you see someone with cognitive decline. Now, so it's not just what the levels are, you want to have the both. So you want insulin sensitivity, and I like to see the ketones, and Heather, I'd be interested in what your take, but I like to see at 1.0 to 4.0 millimolar BHB. That's kind of a guideline.
That's ideal. And some people struggle to get into ketosis. So if you're getting to that 0.5 to 0.9, don't worry, you have arrived. You're making ketones, even if they're in that kind of mild ketogenic range, you're still getting improvement. So one of the ways to bump that up is to use some exogenous ketones, as you suggested. But exactly the same levels, 1.0 to 4.0 is that ideal range. And so she also goes on to ask, what is the preferred testing for tracking memory changes over time, and how often should the testing be used?
It's a great point. And what's happening now is we're getting more and more of an armamentarium. We have more and more things we can do. In fact, one of the things I wanted to talk to you about today is the big problem we're all facing is as the armamentarium grows, the cost grows. So people are saying, well, you have to do stem cells, but they're very expensive. Oh my gosh, you got to do EWAT, it's expensive. You got to do HBOT, it's expensive. You got to do all these things. So it's going to be helpful for us to understand what are the most important things that will have the biggest outcome for you without making it ridiculously priced. So I think that that's a big issue going forward. Sorry, so I got off on this other track.
Well, it's such a great point. And, we use inexpensive testing. We use the MoCA score. This is the Montreal Cognitive Assessment. It's a free PDF. You do need a trained, it doesn't necessarily have to be a clinician, but a technician, somebody who is trained to administer the MoCA needs to do it. So making sure that you choose the SLUMS test or the mini mental status is also available. We prefer the MoCA, but you have a great point about how expensive this can get. And in the book, we have an entire list of things selected from the book that are free. So in the back, there is a list of free things that you can do. Some things that come to mind are exercise, meditation, or a daily prayer practice, prioritizing your sleep, changing up your diet so that you're in ketosis. These are foundational things that are absolutely free. Yes, they take some effort, but we don't have to get the expensive stuff is icing on the cake. Unless, if you've tried all those foundational pieces and you're still not getting better, get extra help and support. And I wish this were covered by insurance. I think that's a lot of the next sort of steps in this world is how do we get reimbursement for this? But we're working on it. We're working on it. So what is your favorite
mention
test?
one other thing. So
Yeah.
for follow-ups, number one, you mentioned the MoCA, and yeah, once a month is good, or even a couple months. CNS vital signs once a month is good. For our trial, we're doing the MoCA every 3 months, and we're doing CNS vital signs typically every month. And it's good to have complementation to say, are things getting better? So you could do p-tau 217 and repeat it in 6 months. It takes some time to change your p-tau level. So you can repeat it in 6 months is a good one. And then if you're doing electrophysiology, things like quantitative EEG or neurocatch or things like that, you can do that after a month or two as well. So with all these things, you can see if you're going in the right direction and see if you need to change direction.
Yeah, that's what we really want to be using them for. Are we on the right trajectory? Are we going towards the target? Or do we need to look further? Do we need to do more of that detective work and switch it up? Next question is from an anonymous attendee. Thoughts on, I'm not sure even how to say this,
Donanemab. So this is coming from Eli Lilly, and this is an anti-amyloid antibody. And so the problem with these is that when we talk about improvements, we're talking about you started here and you went to here, and then we want to keep getting you better. And then we're saying, and we have a thing now that's a paper it's in review, but it's already preprint, freely available online. You could see it, where people got better and stayed better for over 10 years. So that's what the goal is. Now, when you take the antibodies, you don't get any improvement. What you do is, as you have a natural decline, you decline slightly slower. And on donanemab, it's been 32 to 35% slowing. So instead of going like this, you go like that. But it doesn't make you better. Now, when you get these, you have a risk of cerebral microhemorrhage, because what you're doing is you're ripping out. That's just my concern is that the dose that they're using rips the amyloid out of your brain, including out of the blood vessels. So they hemorrhage, no surprise. And the second thing is it's causing the brain to swell. There have been a few deaths. So it is an imperfect drug. As people have said, look, we recognize this is not the final answer, but is it better than what we have? Well, if you ignore all the publications that Heather and others have been showing, like, yeah, we can make people better, then it's better than nothing, sure. But the problem with it is that it's got these side effects. It's ridiculously expensive. These are typically, by the time you have to go in for scans, you have to get infusions, you have to pay for all that. It's about $50,000 per year.
And I think
So
patients, even with Medicare coverage for like Leqembi or lecanemab, they're looking at like $8,000 out of pocket, is my
yeah,
understanding. So
yeah.
if you spent that $8,000 on functional medicine, you could that would take you pretty far in terms of supplements, medications, potentially like bioidentical hormone replacement, testing, seeing doctors who are trained, who've been trained by Dr. Bredesen. There's a lot of value you can get for that $8,000 working with a functional medicine provider. So things to consider. I think there's still a lot of value in seeing a neurologist. That's one of the things that working with the PNI group at Pacific Neuroscience Institute in Santa Monica, I've just really value a lot of the MD, the conventional perspective. There's so much value in it still, right? If somebody has a normal pressure hydrocephalus, getting some imaging to rule that out is really important
Yeah.
because that is a very treatable form of dementia, right? There's a lot of workup that we can do, and sometimes you need to advocate for yourself. But when we can rule out these treatable causes of memory loss,
Yeah.
I think then it really puts emphasis on doing this functional medicine work, on using your approach, but not at the exclusion of doing a good conventional workup.
Exactly. I think that's very important. The other thing is that a conventional workup is very good with diagnostics. They'll tell you, oh, wait a minute, this might look like Alzheimer's, but actually this person has frontotemporal, or they have Lewy body, or they have mostly vascular, or they have PSP, or there are all these other things. And so you want to make sure that it's not that. You want to make sure. And then every once in a while, you're going to see someone who presents with cognitive change, and it turns out to be a brain tumor. Of course, you don't want to miss that. So there are important, I think it's important to get an idea of what's going on, and then to be able to treat it optimally.
So from Daryl, he's asking, I have ApoE 3/4 and a high heart calcium score. Would taking MCT8 be okay for me to help me get into ketosis?
Yeah, great point. And so if you're a 3/4, what I recommend is not to take MCT because it is a saturated fat, and to use ketone salts or ketone esters. So it's a great alternative. It will bump your ketone levels. It will not bother your blood vessels. You do not be taking saturated fat, and I think it's really helpful. And when I was training, we thought of cognitive decline for people 60s, 70s, 80s, 90s. Then it became that, okay, 20 years before that, you're seeing biochemical changes. So then, oh, wait a minute, we're really talking about 40s and 50s. Now we're realizing these things are even changing in your 20s and 30s. And so it's a good idea to make sure that you're not insulin resistant, that you're doing the right things. And I have to say, a very concerning paper just came out in the last couple of days, where what they were doing is looking at people who were ApoE 3/4 versus 3/3. Just that. They didn't even look at the 4/4s, just the 3/4s versus the 3/3s. And what they were trying to see is when you are shown something and you're trying to learn it, does it help you to do exercise? So they broke each one into two groups, exercise, no exercise, and then they would check later. And they were trying to look for, okay, will the exercise help? What they found was shocking. 18 to 25-year-olds, they could already see the difference between ApoE4 heterozygotes and ApoE 3/3s. So again, this tells us what ends up way in your 60s, 70s, 80s, 90s as significant cognitive decline has got some of the earliest detectable changes in your teens and 20s. And so it's never too early to get healthy.
I couldn't agree more. From Randall, can you be diagnosed with Alzheimer's dementia and not have amyloid plaque building up?
Yeah, this is such a good point because we really do need to change the way we think about this. Currently, the definition of Alzheimer's is a pathological one. So it means you have amyloid, it means you have some phosphotau, neurofibrillary tangles with phosphotau, and it means that you have some degree of inflammation. And it's typically, things like microglial activation, astrocyte activation, things like that. You don't have a lot of lymphocytes and things like that. It's not like MS. It is more of an innate immune system. So you really currently cannot make the diagnosis of Alzheimer's if there is no, amyloid. Now, again, that's kind of arbitrary because you can have all the other things driving the same sort of thing. But if you don't have the insults that are giving you, and this is really, if you didn't have the various microbes. So you can imagine a scenario where it's all about just the energetics. You reduce the energetics, but you didn't create the inflammation. And theoretically, you could have the rest of the Alzheimer's phenotype without having the amyloid. But in general, what we see is, yes, the amyloid goes, and Dr. Lee Hood has suggested that, in fact, the amyloid is related to energetics as well. So he would probably argue that if you just drop the energetics, you're still going to get that amyloid. So if the amyloid is not there, first thing is to think about what is the diagnosis. Now, there are things like late, where people are getting, very late in life, they're getting mostly a limbic disorder, but this looks very much like Alzheimer's without amyloid. In this case, instead of the amyloid, you get TDP-43. So that's something to think about. And then there are other things. Is this going to be frontotemporal dementia? Are there other toxins that are there? So there are other possibilities.
Right. What about taking statins? Can these cause problems with brain issues?
Yeah, and I would love to hear your weigh in on this as well. I think what's happening with statins, yeah, and I'm concerned that the problem has always been paper after paper after paper. One will show a slight improvement with statins. One will show slightly worse with statins. Then another one with slight improvements, another one slightly worse. And the answer is because they have a positive and they have a negative impact. They are giving you an abnormal lipid profile. They're changing that, and you should be able to change that without the statins in most cases. And we go through, there's several things. Bergamot is a good way to go. Zetia, a nice paper that Craig Tanio sent all of us, showing improvements with Zetia, so you don't need to go to a statin. And then there are even things like PCSK9 inhibitors, like Repatha, that if you really have to go that direction, think about that. So I don't love the statins, but for some people, if you're going to do it, use a hydrophilic one, like a Crestor, and not a hydrophobic one like a Lipitor. And so I do think there are better ways to go. And as you know, repeatedly, and you mentioned this in your book, you see people coming off their antihypertensives, coming off their statins, coming off their anti-diabetes drugs because they don't need them anymore because they're doing the right things.
Yeah, so we see even going into ketosis, you can have a very heart-healthy ketogenic diet. And although in the first 12 weeks or so, we'll see total cholesterol levels go up, usually by 6 months, those cholesterol numbers are getting better. We see our HDL improve, LDL improve, LP(a), our fractionated lipids, that ApoB, that it kind of gives us the best sense of risk, goes in the right direction on a healthy ketogenic diet. And when you're using the extra omegas and you're getting the exercise and you're getting the sleep, we tend to see those lipid profiles improve just with diet or just with our entire approach. And I, like you, am a fan of Zetia, which helps to reduce the absorption of cholesterol versus being an HMG-CoA reductase inhibitors. Many people are surprised to hear me say, I am not a fan of red yeast rice. Yes, it's a supplement, but it's not well regulated. It's not as streamlined as the statin industry is. And so you have a lot of unpredictability, but statins and red yeast rice, they work exactly the same way. They both reduce CoQ10. So say you have a loved one who's not getting off statins, they're on statins, that's the way it's going to be. Make sure that they're getting a CoQ10 supplement. And then I'm also a fan, you mentioned Neil Nathan earlier, I'm a fan of cholestyramine. We use this for mycotoxin detox, but it's called cholestyramine because it was designed to reduce cholesterol levels. It's not that good at it, but it does work for some people better than others. And what it does is bind bile. So it helps us to detoxify and it can help to reduce our cholesterol levels. So you mentioned bergamot, niacin, berberines are something that also come up, but they can really affect negatively, potentially our gut microbiome. So I don't like to use those long term. We can use them temporarily, maybe while we're changing diet, exercise habits, but we have like you say, an armamentarium. I think of it like a tool belt or a toolbox that we can reach into. We can try a lot of different things and work closely with a provider to arrive at those ideal cholesterol numbers so that we reduce both heart risk and brain risk. So really exciting stuff. From Diane, I watched your recent summit. Can you talk about MitoPure, adaptogenic mushrooms, and chlorella and spirulina potentially benefiting patients with Alzheimer's? Will these help if I can't get my mom into a ketogenic state?
Yeah, and these each one of these hits again. If you look at the concept here, we're trying to improve the energetics and things like that. So each of these is addressing a different piece, and so we use them depending on what we think are the main things that are driving this. What is your take on these, and do you like any of them particularly more than the others?
Yeah, so I know chlorella, I think of for detox, just we were just talking about cholestyramine, and chlorella is one of these great binders, but it also it's a food, so it can help to increase B12 and other B vitamin levels. And so that's one that I go to quickly. And mushrooms, I'm a huge fan of adaptogenic mushrooms, but also turkey tail and lion's mane, and there's a bunch of nootropic mushrooms. And I
Yeah.
tend to look for a blend because they work together synergistically. And my preference personally is to drink them in tea. I don't know if everybody loves that flavor, but I do. I really enjoy it. And so I have that regularly with my brain health in mind. Now, I don't think using any of these one things, like you mentioned, there's never one thing. We can increase nutrients, we can increase those signals to the brain, but we need to have the right energetics. We need to make sure that the toxins are coming out. We need to be getting exercise. We need to look at multiple components. This is a multimodal approach. And we can't rely on one thing to make a big difference typically. The Memories for Life movie, near the end, there's an older man who had lots of amyloid plaque, but wasn't diagnosed with Alzheimer's. What's the follow-up? I don't know if you know that.
A man who had lots of in memories for life. So there was Frank, who has continued to do well. And he actually kind of fell off the wagon briefly and didn't do as well. And this is another thing. You see this all the time. People kind of they stop doing the right things. They clearly get worse. They do the right things. They clearly get better again. There was David. I'm trying to think of who else. So Lucy has continued. Lucy also had a little issue with some toxins. She's detoxing again, but just wrote to me a couple of days ago, and she's detoxed, and then she's doing better once again. So always great to hear from Lucy. And I'm trying to think who's the guy who had lots of amyloid.
It wasn't the Japanese fellow, was it?
Oh, Sobu, maybe. Now, Sobu had really significant, really toxicity and really didn't ever get. I mean, this is where I wish that Sobu had been at Marama. And there was a health coach who was working with him and really kind of didn't stick with and so I have not heard recently about Sobu. And my concern was he was struggling, as they mentioned in the movie, that he was struggling to kind of get this. And because it is recognized at first, it is overwhelming. There's a lot to do, and I wish the disease were simpler. I do think we'll get better and better at doing things simpler and simpler. This is where I think that AI is going to be helpful in the long run to help tell us, okay, these are the top few things that you need to do. Right now, we all try to figure it out. What are the most important things for each person? But if you're talking about Sobu, then he was not doing well, and so I don't know that I haven't heard recently. Actually, I wrote to the person who was caring for him a couple of months ago, and I have not. I wrote to her a couple times, and I have not heard back from her, which is probably not a great sign.
That's rough. Okay, so it is 5:15 p.m. I don't want to make your family upset if we need to get you home for dinner. But we have tons of questions, and I'm happy to stick around for another 15 minutes or so to answer them. If you have the time,
Yeah, let's do some more questions because I think
always a privilege.
this is a very important book that you're getting out here. Reversing Alzheimer's is part of changing the world. As we talked about before, if we could just get people to come in for prevention or SCI, so many people would do better. And one of the big problems is everybody is taught, as you mentioned in the movie, that nothing can be done. And so that's, as you said, that's what we think is true. And so I think that we've got to change that thought pattern. We got to change that belief. And I think your book is helping to do that. And you are offering this wonderful toolkit for everyone. So I think this is a very, very important book. Let's take some more questions, and then we can go till 5:30.
All right. From G, I was told my mom has vascular dementia. Is this the same or different from Alzheimer's? And how are the treatments and symptoms different?
Such a good point. So when I was training, we were trained to calculate a Hutchinski score, which was whether is this vascular dementia or is this Alzheimer related dementia. And the thought was these two have nothing to do with each other. Of course, that's turned out to be completely wrong. They are actually closely related. So again, it comes back to energetics. Are you supporting that tissue? Now, if you have more, it's the vast majority is vascular, then they tend to call this vascular dementia, and you may not see much amyloid, just as we were talking about a few minutes ago. You may not have a lot of amyloid if there's not a lot of inflammation there. But most of the time, you'll have some of both. In fact, it's been pointed out that it is more common in the Latinx culture in the United States to have a mixed dementia with both amyloid and vascular than it is among others. So that's something to keep in mind if you're treating people who are coming in. So the thing is that I tend to like to include a triad when someone has a significant vascular component. And I think of vascular dementia as just being an Alzheimer's case that has virtually 100% vascular and not much in the way of the other, although usually they do have a little toxicity or a little insulin or something like that. But the triad I like is nattokinase, and then arterosyl HP. So you're rebuilding that endocalyx. And then also some nitric oxide, whether you like to use, super, whatever you like, Neo 40, super beets, beetroot juice, whatever you like. That way you're getting some dilation, you're getting some repair, and you're getting some you're getting some reduction in clot formation. So that's kind of a beginning. Now there's more to do. It's also why I like EWAT so much, because it doesn't give a big bump for everybody, but for so many people who aren't getting that combination of blood flow and oxygenation, you're addressing both of those at once. And I really like it for people who have a large vascular component. So Heather, what do you do when you see someone with vascular dementia?
Yeah, so we're following those lipid profiles really closely. Of course, really emphasizing exercise and then sleep, working up sleep apnea and making sure that people are aggressively treating their sleep apnea, because that combination between heart health, brain health, and the risk of cardiovascular disease and vascular dementia goes up a lot when we have obstructive sleep apnea. And so again, I feel like it is multifactorial, and a lot of it is lifestyle when it comes to vascular dementia, but there are also the familial hypercholesterolemia and those lipid panels. Sometimes people don't realize just how vulnerable they are to having plaque buildup. And so aggressively getting after that. I love those suggestions. We also do, of course, fish oils and the SPM active that I know you're a fan of. We want to get those inflammatory levels down. And you mentioned that I'm kind of surprised. I'm learning it from you right now that there is a less inflammatory component when there's vascular dementia. But I
They
tend to.
sometimes have an inflammatory component, but if it's much inflammatory, they're going to have amyloid there. So
Okay.
that's why I was saying if it's truly pure and you don't really not going to see the amyloid, then it can't be too. I mean, there may be some inflammation in the vessels. And again, what's really interesting, this is a systemic change where you're going from connection to protection. And part of that entire shift is that you are increasing the thrombotic nature. As you know, the vasculature becomes more prothrombotic. And that's what you're seeing with COVID-19, for example. And I really worry about this because we have seen so many people who are doing fairly well, and then they got COVID and then things fell off, or they got anything that activates their innate immune system and they tend to fall off, trauma, surgery, any of these new things that come, and they tend to take a back step. So you really have to work with them to get that to go forward again. And one of the most common is in a viral infection like COVID.
Well, that's exactly the patient that I was just thinking of, who has vascular dementia, diagnosed vascular dementia based on imaging, had COVID several times, and has an elevated hsCRP, elevated cytokines. And so maybe the COVID and the vascular dementia are working together to exacerbate the cognitive decline, this post-COVID syndrome. So really interesting stuff. Thank you so much. Mary is asking, I've read recent studies that show that sleep doesn't really detoxify the brain. What do you think on that score?
Well, so, there's no simple way to just kind of pick up a blood sample and say, how much did you detoxify your brain last night? So this is really based on two things, mainly the glymphatics. There's been a lot of work on the glymphatic system and how, to get your glymphatics activated, you have got to tone down your noradrenergic tone. The noradrenergic tone is what prevents you from having that glymphatic opening. You really open up and essentially wash out things. So I think you can't deny that there's some degree of detox going on. The other thing, of course, is autophagy. You're eating up this stuff, you're recycling it, you're getting rid of this. And it's been one of the things that was impressive to me years ago is just doing an experiment where people would stop you from having mitophagy. And what happens is you develop Parkinson's. So you need to recycle your batteries. You need to recycle your mitochondria. You need to recycle these various damaged components. And I think that so I don't quite know where this idea is coming from that you don't detox. Certainly, for everything I've seen, there is some degree of which doesn't mean you don't need a detox during the day too, but it is part of an overall optimal approach.
My understanding as well was that people who were sleep deprived, even in their 20s, 30s, or 40s, after just one night, there was measurable amyloid buildup in the cerebral spinal fluid. So whether we're detoxifying mercury or mycotoxins or amyloid plaque, that sleep was essential to getting, well, maybe it's not plaques at this stage, but getting amyloid out of the brain.
And one of the things I've seen repeatedly, and I'm sure you've seen it as well, for the people who have the type 3, the toxin-related cognitive decline, they are hypersensitive to stress. So I see them, they get on red-eye flights. They have a problem. They go in for surgery. They have anesthesia. They have problems at home. Anything that really increases the stress and they fall apart. So they are very, very sensitive to any of these sorts of things.
When I was able to come up to the Memories for Life documentary, somebody asked you about anesthesia. And I learned a lot from you that night. So would you share, if you have to go in for surgery for some reason and you are concerned about your cognition, what are some of the things, the conversations that you can have with your doctor, questions you can ask to reduce the risk of anesthesia as you go in for a procedure?
That's such a good point. And by the way, we have a list of this in the book, for example, in the End of Alzheimer's program from several years ago. There's also a guide in Apollo and things like that. But here's the thing. When you go in for surgery, that is, first of all, it's a huge stress, of course, but it is also toxins, and it is also often some hypoxia, and also often some ischemia from dropping the blood. They tend to let the blood pressure come down too much. So you kind of have a series you go through. Go ahead of time, meet with the anesthesiologist or talk to him or her and say, please don't let my blood pressure drop too much. And please make sure that my oxygenation is very, very good. And please, don't go too long. You try to keep it to a minimum. That's more obviously going to be up to the surgeon. And that's the first thing. The second thing is get your glutathione level up, get your vitamin C level up, get your detoxicants optimized before you go in, so that when you go in, you are as resistant as you possibly can be. If you go in and you're on the edge of toxicity already, it's going to be a disaster. And one of the most common things we hear is that, my spouse or my mother or whoever, she was doing fairly well until she or he had an operation, had 2 hours of anesthesia, and then has gone downhill since then. So it is a huge stress on your brain. Optimize those things ahead of, and then as soon as you've had the surgery and you've made sure to keep the blood pressure good, made sure to keep the oxygenation good, and then afterwards you want to go in and detox again. You might even want some IV glutathione. Get your detoxing going. Make sure that the basics, you have the appropriate filtered water, you have the appropriate high fibers, all these. Think about this as that there's going to be a toxic burden supported by now a stress burden with all this at that time. So if you know that ahead of time, you treat it, and then you can treat it afterwards as well. It gives you the best chance to come through this without any problems.
Excellent advice. We have someone joining us. It sounds like she has an aunt who lives in Sierra Leone. What advice would you give to help someone who is living in a place like Sierra Leone, outside of the US, outside of the Western world? My understanding is that the incidence of Alzheimer's is, although per 100 is going down in the Western world. We have this huge demographic shift, but in third world countries, the incidence is actually increasing for Alzheimer's. And I'm sure we could talk for days about, why that might be, but how do people in that sort of situation go about getting support?
It's a great point. And, actually in the movie, Deborah was the one who said, it doesn't take a lot of money to do this. It takes willpower. So I would start with the basic 7 things. And then if you have problems, now I don't know if this person is prevention or is symptomatic already, but if you have problems, then you want to kind of take it to the next level, go to a doctor. But everyone can do the 7 basics. So that's getting a plant-rich, mildly ketogenic diet. And I know, Heather, you have a remarkable background in appropriate food and what to do with your nutrition. So, whatever you think, but you want to have those basic things. You want to have the detox, you want to have the plant-rich, you want to have good, clean animal protein, etc. Exercise. And, even you can get some stress bands. They're very inexpensively easy to get. There's a lot you can do with that. Sleep. To get wearables, are changing the world. So no matter where you live, you can get a wearable and really and help yourself and see how's my sleep. How was your last night in terms. You want an hour of deep sleep. You want an hour and a half of REM sleep. You want a total of at least 7 hours. And then stress. Things to do. Get out there. If you're in Sierra Leone, get out and walk and relax yourself. Get whatever you like to get things to be relaxed. And then some brain training, and there are lots of ways to do that, obviously. And then some detox, and then some, maybe a few targeted supplements, things that you can do. Again, if you can do these through diet, it's even better. Omega-3s through your diet, that's better. So there's a lot you can do. Then with those things, you should be able to do very well. If you then start having problems, then you want to find a referral, and it might be worth a plane trip to someone who's well trained, or it might be worth a Zoom with Dr. Sandison or one of her trainees or someone like that, or the PNI or somebody like that. So there are all sorts of ways to go.
You've trained medical professionals, health coaches all over the world. How many is it now? Thousands, right?
Way over 2,000. And they're in 10 different countries and probably more than 10 now. But and all over the U.S. So there are a lot of people who are doing this. Now, to be fair, some of them are trying to do it their own way and trying to ignore some of it, which always worries me because, are they going to get the best outcomes? We're always looking for the best outcomes. So I do think that there's a lot that can be done no matter where you are.
I could not agree more. Dr. Bredesen, thank you so, so, so very much for joining us tonight. It's a pleasure to have you here. I'm going to give everyone a little bit more information about how to get my book. That's the right way. It's called Reversing Alzheimer's. It's available wherever you buy books. It will release on June 11th. And thank you to every single one of you for being here. You are part of this Reversing Alzheimer's movement. You are part of the end of Alzheimer's movement. You are part of making dementia rare and optional. We are working together. This community is so valuable. And so I couldn't be more gracious. I couldn't be more grateful that you are all here. And when you buy our books, it helps us to get the word out. If you give one to a friend, if you can help us by getting books early on, it helps us reach those bestseller statuses that then it creates that momentum that gets more people access to this information. So Dr. Bredesen's book was a New York Times bestseller, and that I'm sure generated a ton of momentum for you. So anyone who is doing that is ordering a book, especially in pre-sale, so that the publisher can print more of them and more people can get access. This is a huge, huge, huge way for us to get access to more people. So thank you, thank you, thank you, thank you to all of you for being here and for being part of this community. Dr. Bredesen, any parting words for?
Yeah, thank you for writing this important book. I hope that many, many people will read it because I think it will be very, very helpful in reducing the global burden of dementia. So thank you, Heather.
That's our goal. And thank you for writing the foreword and for all of your support. Thank you, everyone. I will be back here next Wednesday at the same time to answer more questions and to celebrate Alzheimer's and Brain Awareness Month with you. So let's all work together to spread the word that there are things that we can do to prevent, delay, and even reverse dementia and Alzheimer's. Thank you all so much. Have a good night.